Good afternoon and welcome to today's webinar, Symptom-Limited Exercise Stress Testing, Why and How. My name is Kelly Baer and I am the Creative Design Manager with Marketing Communications at IAC. Before we begin, I'd like to take a moment to review a few technical matters and let you know how you can participate in today's session. We would like today's webinar to be interactive, so we encourage you to submit questions. To do so, use the Questions tab located on the left side of your screen. Please submit your questions anytime during the webinar, as we will be monitoring questions throughout the presentation, and we'll try to answer as many of them as possible during the Q&A period. Also on the left side of your screen is the Resources tab. Click on this tab for links to today's handout, a PDF copy of these PowerPoint slides. Select the file name to download the handout. Lastly, in the lower left of the player, please note the Request Support button. If you experience any technical problems during the course of this webinar, you may click this button. A technical expert will be there to assist you with any issues you may have. For those who like to take notes during the presentation, look to the right of the slides and click the Notes tab. There you will see a white text box where you can take notes on today's webinar. These notes will be emailed to you automatically at the end of the session. To be eligible for the SNMMI CE credits, you must be registered, logged into this webinar, then complete the survey. The survey will open automatically at the conclusion of the live session and be available from the IAC Pro Libraries website for 3 business days. If you are viewing this webinar in a group, please be sure you are also individually registered and logged into this webinar on another computer or device so that we have record of your attendance today. Today's presentation is being recorded and will be posted at a later time for on-demand viewing. And now I would like to introduce today's guest speaker, Dr. Mylan Cohen. Dr. Cohen practices clinical cardiology with Maine Medical Partners, Maine Health Cardiology. He is the medical director of the Imaging and Diagnostics section of the Cardiology Division at Maine Medical Center. Dr. Cohen is also clinical professor of medicine at Tufts University School of Medicine. He serves as the president-elect of the IAC Nuclear PET Board of Directors representing ASNC, and his activities include clinical care of patients, administration, research, and teaching, and we are honored to have him with us today. With that said, I will turn this webinar over to today's speaker, Dr. Mylan Cohen. Doctor?
Thank you, Kelly. It's a pleasure to be here with all of you today to talk about what I think is a very important subject. Let's just start the discussion with a case. So this is a case of a 65-year-old male marathon runner, and he's developed some mild dyspnea, reduced exercise capacity, and he's noticed that when he's running, his times have slowed down. And if any of you are runners out there, you recognize this as just a horrible thing that happens to some runners. Runners are acutely aware of their finish times of any race, and so this is a marked change for this 65-year-old marathoner. He also has hyperlipidemia. He had a left circumflex coronary stent for angina about 10 years ago, and his medications currently are atorvastatin, 40 milligrams daily, and aspirin, 81 milligrams daily. He's referred for stress testing, and at baseline, his heart rate, not surprisingly, is 50 beats per minute, and his resting blood pressure is 110/66. His baseline electrocardiogram shows sinus rhythm, nonspecific STT wave abnormalities. So he exercises along on the treadmill. He's at stage 4 of a Bruce protocol. He has no symptoms. And his heart rate now is 132 beats per minute, which represents 85% of his predicted maximum heart rate. His blood pressure is 201/80, and the ECG shows no significant ST segment changes. So at this point, let's just poll the audience here. The next most appropriate step in this case is A, inject radionuclide. The patient is at 85% predicted maximum heart rate and has a high blood pressure. Or B, administer a nitrate to lower the blood pressure. C, continue exercise. Or D, all of the above. So let's take the poll. And then we're going to come back to this case at the end of the presentation, and we'll discuss the answer based on what we learned today during this discussion. The objectives of today's presentation are the following. By the end of the presentation, you will be able to explain why symptom-limited exercise stress testing is performed, explain what symptom-limited exercise means, explain how to perform symptom-limited exercise testing, know when to switch from exercise to pharmacologic stress and when to abandon testing altogether, explain the content of a typical stress test report, and know which ECGs the IAC requires to be recorded and submitted and why. In order to accomplish those objectives, this is the agenda for today's discussion. We're going to talk about the indications and clinical utility of exercise testing, the definition of symptom-limited exercise, the rationale for symptom-limited exercise. We'll talk a little bit about exercise physiology in order to understand some basic concepts that will bring clarity to these other topics. We're going to talk about stress protocols, how to perform symptom-limited exercise testing, that is, the nuts and bolts of stress testing. I'll demystify the stress test report for you, and we'll talk about required ECGs. We should have plenty of time at the end of the presentation for question and answers. So what are the indications for exercise testing? These are really the most common indications. First, the detection of coronary artery disease. Next, the assessment of functional capacity. This is necessary for a host of reasons, including enrolling a person in cardiac rehabilitation, for example, assessing risk. Speaking of risk assessment, we often use exercise testing in the post-MI setting or in patients who have chronic coronary artery disease and we want to assess how they're doing. Perhaps give them an exercise prescription or let them know whether they can engage in certain activities. And exercise testing is often used for risk stratification before non-cardiac surgery. We also use exercise testing to evaluate the efficacy of therapeutic interventions, whether that be medical therapy or perhaps stenting of an artery, realizing that there might be incomplete revascularization, determining whether a modest lesion is significant and whether we need to proceed with further interventions, for example. So the utility of exercise testing is that it allows us to establish a diagnosis related to the symptoms that a patient may be having. That may be chest pain, it may be dyspnea, it could be other symptoms. It allows us to determine the extent and severity of coronary artery disease, which often guides our therapy. It allows us to define prognosis, and it helps us establish the adequacy of therapy after we have chosen a management strategy. Here are some of the indications for early termination of exercise. These are taken from exercise guidelines, and we'll walk through these. Moderate to severe angina pectoris, marked dyspnea, fatigue, it could be profound fatigue, often affecting the patient's motivation for continuing the test. Ataxia, dizziness, or near syncope. We want to make sure that we're continuing to perform a test that's safe for the patient. Signs of poor perfusion, such as cyanosis and pallor. Patient's request to terminate the test. Excessive ST segment depression, and that's defined as more than 2 millimeters of ST depression from the baseline in an interpretable electrocardiogram. ST elevation, more than 1 millimeter in leads without diagnostic Q waves, except for leads V1 and AVR. Diagnostic Q waves, of course, signaling a possible old myocardial infarction. Sustained supraventricular or ventricular tachycardia, the development of left bundle branch block or interventricular conduction delay that cannot be distinguished from ventricular tachycardia, drop in systolic blood pressure of greater than 10 millimeters of mercury from baseline, despite an increase in workload when accompanied by other evidence of ischemia. Hypertensive response, and this is defined as a systolic blood pressure greater than 230 millimeters of mercury or a diastolic pressure greater than 115 millimeters of mercury. I think this is a very important point and one that's really misunderstood by many people, including physicians who supervised stress test. This is right out of the American Heart Association guidelines. And we'll talk about the physiologic response of blood pressure to exercise in this presentation. It will help you understand this guideline. Another indication for early termination includes inability to monitor the electrocardiogram or the systolic blood pressure. And in patients with an implantable cardioverter defibrillator, when the heart rate attained is within 20 beats per minute of the lowest heart rate at which therapy, either anti-tachycardia pacing or shock, is programmed to be delivered, thereby allowing us to stop exercise before the patient might receive therapy, which could be very uncomfortable or detrimental to the patient. So the crux of what we're discussing today is the definition of what symptom-limited exercise is. So what is symptom-limited exercise? And I would define it as exercise testing performed to the patient's maximum tolerated exercise, guided by symptoms or other guideline-defined indications for test termination, like those that we just discussed on the previous slide. I think it's very clear to state that symptom-limited exercise is not defined by attaining a predetermined heart rate or level of energy expenditure. So according to the ASNC imaging guideline published in 2016, achievement of 85% of maximum age-adjusted predicted heart rate is not an indication for early termination of the stress test. I think this is something that you're going to hear several times during this presentation, and is a very important concept to come away from this presentation with. Let's change gears now for just a moment, and we'll talk a little bit about physiology. When we talk about exercise physiology, there are two basic principles underlying what we do in an exercise lab. First is myocardial oxygen consumption, and the second is ventilatory oxygen consumption. Myocardial oxygen consumption is roughly dependent on heart rate times the systolic blood pressure. These determine wall tension, which is proportional to left ventricular pressure and volume, as well as contractility and heart rate. So oxygen consumption is dependent on all of these factors, while ventilatory oxygen consumption is proportional to external work performed or cardiac output times the arteriovenous oxygen difference. And that arteriovenous oxygen difference is generally around 15 to 70% volume percent at maximum exercise. Therefore, VO2 max is a non-invasive method for estimating cardiac output. So when we look at what the determinants are of maximum oxygen uptake, they're listed here on this slide from a paper by Myers and Frelicker in the Annals of Internal Medicine. So if we look at what determines cardiac output at the top of the figure and work our way, actually, let's start at the very bottom line and we'll work our way up. We can look at filling pressure, compliance, contractility, and afterload. Those are some of the factors listed on the previous slide. On the left-hand portion of the slide, we look at filling pressure and compliance and how those help determine end diastolic volume. End diastolic volume, in turn, helps determine stroke volume, which in turn helps determine cardiac output. Heart rate also plays a role in both cardiac output and end diastolic volume. Generally, with increases in heart rate, you have a decrease in end diastolic volume. Slower heart rate allows longer filling times and generally larger end diastolic volumes. On the right side of this figure, you see the factors of contractility and afterload at the bottom. These help determine end diastolic volume and stroke volume. Actually, I think that's a typo. That should be the end systolic volume. Those, in turn, are, as I said, stroke volume also is a determinant of cardiac output. So what about heart rate? As heart rate, as you could see, is a large determinant of cardiac output. We can see from this slide that as people age, as depicted on the x-axis, that the maximum heart rate, depicted on the y-axis, generally decreases as we age. And this is important concept. You know, the 80-year-old is really not going to be able to achieve as high a heart rate as the 40-year-old. And this is true regardless of the type of exercise that is undertaken. This is a plot of maximum heart rate achieved by different types of exercise. You don't have to look at the actual details of which line represents which, but if we look at bicycle ergometry versus treadmill testing, you can see that the maximum heart rate achieved goes down with age. And this is true whether you have a person who is a North American, a European, whether they're sedentary or they're active, or even if they're endurance trained. So like our marathoner at the beginning of the presentation, his heart rate, his maximum achievable heart rate is expected to be lower than someone half his age. So factors affecting maximum heart rate include age, as we just discussed, gender, level of fitness, the presence or absence of cardiovascular disease, bed rest, altitude, the type of exercise undertaken, and whether a person is really engaged in true maximum effort. What about ventricular volume response to upright exercise? As you recall from that figure, ventricular volume is a determinant of cardiac output. And these are a number of studies looking at both radionuclide methods and echocardiography to assess ventricular volume. And if we look in the last two columns, percent change in end diastolic volume and percent change in end systolic volume, we see that across a number of different studies that in general there's an increase in these volumes over when a person exercises. It's not uniform across all studies, but we do see that for most there is some modest increase. What about blood pressure response to exercise? This figure depicts the hemodynamic responses of over 700 healthy men to maximal treadmill exercise, and the gray bands represent 80% of the population, with 10% having values exceeding the upper limit and 10% with lower values. And so what we see here is that as a person exercises across ages, the systolic blood pressure does tend to go up. And if you look on the top part of the figure, you do see that some people may easily hit 200 millimeters of mercury when they exercise. I use as 200 heart rate. I'm sorry, I was referring to the wrong part of the figure. It's the bottom pane. You still see that people attain greater than 200 millimeters of mercury. Sorry about that. I use as a rough general estimate for both males and females a figure of about 7 millimeters of mercury per MET achieved. We're going to talk about METs in a little while, but if you have a person who starts at a heart rate of, say, 60 and they achieve and a blood pressure of, say, 120, and they achieve 10 METs on their stress test, on average, I would expect that based on 10 METs, their systolic blood pressure should go up about 70 millimeters of mercury during the exercise test. So 7 millimeters of mercury per MET achieved, so 7 times 10 is 70. Add that to the 120, and I would expect that their systolic blood pressure at the completion of exercise would be somewhere in the range of about 190. And you can generally say that that's plus or minus about 10 millimeters of mercury, just roughly across both males and females. It turns out that there are also differences in VO2 based on whether a person has heart failure or not, and even within the heart failure population, there's a difference with those patients who have reduced ejection fraction, heart failure with reduced ejection fraction, HFrEF, which you see as a acronym at the bottom of the middle column on the left side of the slide, and also heart failure with preserved ejection fraction, or HFpEF, seen also on the left side. And then if we look at the determinants of VO2, heart rate, stroke volume, and oxygen difference, we see that there are differences. So a normal individual is able to increase VO2 with exercise by about 9 times. The heart failure population is between 3.6 and 4.1 times resting, based on whether they have heart failure with reduced ejection fraction, HFrEF or HFpEF. And then we can compare heart rates, stroke volumes, and the oxygen differential amongst those populations. I think the key takeaway message from this figure is that there's a difference between the heart failure population and normals. So what about performing stress testing? What are the nuts and bolts? Let's talk about that right now. We have a great person who works in our department. His name is Tom Tipton. He loves to draw cartoons, and he decorates our hallways and our stress labs with all kinds of cartoons. And here's one of them. He says, "Hi there, my name's Bruce. Bruce Protocol, walk with me, baby." The Bruce Protocol is perhaps the best-known treadmill protocol in the world, named after Dr. Bruce, who was a professor emeritus until he died several years ago. He was at the University of Washington, and he was an amazing guy. I had an opportunity to interview him for a talk that I gave at the International Conference of Nuclear Cardiology a number of years back. And he was perhaps one of the original outcomes investigators. He assembled a network of physicians in the community who would track the outcomes of patients that he stressed. And they telephoned this in, and they kept records and notebooks. So he was a pioneer in outcomes research. Interestingly, for those of you who are perhaps history buffs, the protocol that now bears his name, the Bruce Protocol, was actually the original modified Bruce Protocol, and vice versa. In other words, when he started stressing patients, it was felt that if you stressed a patient after a heart attack, you'd kill the patient. And so the original protocol was a very slow walk with very gradual increases in grade of the treadmill. And it turns out that original protocol was what we now term the modified Bruce Protocol. And when they realized that they could safely, more aggressively stress patients, the protocol that we currently call the Bruce Protocol was developed. So why am I telling you all this? Well, basically, all these names mean are they're titles for protocols on the treadmill that describe how long the treadmill stays at a certain speed and grade. And depending on the protocol, as you advance in the protocol, the speed and grade of the treadmill changes. So there are other protocols that are out there. There's the Naughton protocol, which is a very low stress protocol, the RAMP protocol, and many, many others, the LSTAT protocol, for example. And the treadmill exercise is very popular in the United States. As opposed to in Europe, bicycle ergometry is very popular because more Europeans are familiar with bicycles. You can stress someone either way. You can even stress someone with an arm ergometer. It's just there's not as much muscle mass to the upper extremities, and so people generally don't go as long and can't raise their heart rate quite as well with arm ergometry. So the two predominant protocols that are used are treadmill exercise and bicycle ergometry. Come on, we're going to take it a little easier this time. So now you understand what a modified Bruce protocol is. So So you should choose a protocol on which a patient can walk at least 4 to 6 minutes. It really takes that much time physiologically for everything to kind of equilibrate and for us to get a more accurate assessment of whether there's ischemia or not by electrocardiography or even radionuclide imaging. So you should inject the radionuclide about 1 minute before termination of exercise. This allows you to have adequate circulation time of the radionuclide and adequate extraction of the radionuclide from the bloodstream into the myocardium. You can think about injecting the radionuclide at less than 85% predicted maximum heart rate if you have provoked symptoms that duplicate the indication and the patient is fatiguing. So if the patient confirms for you while they're on the treadmill, this is exactly why I saw my cardiologist, this is exactly why I'm having this test, at that point the supervising physician or the supervising APP or nurse or exercise physiologist may elect to inject. So according to the ASNC imaging guidelines of 2016, caffeine should be avoided for at least 12 hours, similar to vasodilatory stress testing, because exercise stress tests at times need to be converted to a pharmacologic stress test. Patients referred for a diagnostic stress test may be converted to a pharmacologic stress test or a combination of both if they cannot exercise adequately for a meaningful period of time. Let's talk about the exercise test report, because for many people this is just a bunch of gobbledygook and a mystery as to what exactly it means. So let me walk you through this statement. This is not an unusual statement from an exercise test report. The patient exercised for 6 minutes on a Bruce protocol, achieving a heart rate of 132 beats per minute, representing 85% predicted maximum heart rate, and a peak blood pressure of 175 over 85 millimeters of mercury, or a double product of 23,100. There was no chest pain, 0.5 millimeters of upsloping ST depression noted in leads 2, 3, and AVF, returning to baseline by 1 minute in recovery. Well, what does all that mean? Let's first look at METs. What exactly is a MET? Well, a MET is a measure of oxygen consumption, and it's defined as 3.5 milliliters of oxygen per kilogram per minute. And basically, the more METs that a person can perform or achieve, the better their prognosis. What's 85% predicted maximum heart rate mean? Well, as you saw from those slides that we looked at, looking at maximum heart rate achieved, the predicted maximum heart rate for an individual is 220 minus their age. So you can see how that takes into account the fact that as we age, we can really only achieve lower heart rates. So in order for a test to be considered diagnostic, we generally look for a heart rate that is at least 85% of predicted maximum heart rate, or 0.85 times 220 minus the person's age. So they achieve a peak blood pressure of 175 over 85, and that's a double product of 23,100. What's a double product? Well, a double product is the rate pressure product. So this is calculated by taking the maximum heart rate that a person achieved on the stress test and multiplying it by the peak systolic blood pressure achieved. So in this case, it's 132 times 175, and that equals 23,100. 0.5 millimeters of upsloping ST depression noted in leads 2, 3, and F. Well, what's that all mean? Before we go to the next slide, I'm just going to tell you that it's most appropriate to talk about which leads ST depression or ST elevation is seen in, because the exercise leads, especially in patients who are performing exercise in upright position, does not reflect where there might be ischemia in the heart. The axis of the heart becomes more vertical when a person stands up. And so even though a number of people who interpret exercise tests will say, perhaps for brevity, it's a little easier for them to say it, oh, there was 0.5 millimeters of upsloping ST depression in the inferior leads. They're really not the inferior leads, because ST segment depression in those leads doesn't mean that you have inferior ischemia. So it's really most appropriate to talk about which specific leads by designation, meaning leads 2, 3 AVF or leads V4 through V6, for example, are affected by ST depression. So what does it mean by upsloping ST depression? So on the left you see no ST depression, or basically normal. And the ST segment, or whether there's depression, is measured at 80 milliseconds after the J point. That's according to guidelines, 80 milliseconds. Those of you who are used to looking at the 12-lead EKG that comes out of the monitor when you're performing exercise testing, you see large boxes on there and you see small boxes. 80 milliseconds is generally 2 small boxes on the x-axis. So we measure ST depression 80 milliseconds beyond the J point, and the second QRS complex from the left shows you what J point depression is. So it is normal, it's physiologically normal to have a little sagging of that ST segment, but it should reach the isoelectric, defined as the TP, where the TP, the T wave and the P wave hit the baseline. It should hit that by 80 milliseconds. So another thing you sometimes see in reports is people will talk about, there's 2 millimeters of J-point depression. I really think it's not worthwhile putting that into a report because it really is meaningless. That's just normal physiology and really doesn't mean anything as to whether it's a positive or negative test. Instead, you really want to determine what the ST segment is doing 80 milliseconds beyond the J point. And in the middle QRS complex, you see an equivocal standard ECG response, and this is greater than or equal to 1 millimeter, but it's upsloping, okay? Now, the guidelines allow you to say if it's very slowly upsloping that it might be a borderline positive test. That's kind of in the eyes of the beholder and requires some experience to make that determination. More importantly, I draw your attention to the right side, those last 2 QRS complexes, horizontal ST depression and downsloping ST depression. So QRS complex number 4 from the left, that one represents more than 1 millimeter of flat ST depression or horizontal ST depression, and that's a positive response. Even more diagnostic and with a higher positive predictive value is downsloping ST depression, depicted in the right-hand most QRS complex. This brings us to which ECGs are required. So we need to take a baseline standard 12-lead ECG, and because of the heart changing position in the chest, as I mentioned a moment ago, when someone assumes an upright posture, you need to look at the exercise leads as well. You should check the ECG at each stage of exercise, at peak exercise, and termination of the recovery phase. In case of abnormalities, for example, arrhythmias, a 12-lead ECG should be obtained as well. Additionally, you need to monitor at least 4 minutes into the recovery phase. In our lab, we monitor for 5 minutes. Resting heart rate should return to close to baseline, and exercise-induced ST segment changes and symptoms should resolve. So just because you hit a magic 4 or 5 minutes, if the patient is still having symptoms or ST segment depression, you want to extend that monitoring period in recovery. Let's return to our case here. Let's go through this a little bit more, and then we'll bring it all home and have some time for question and answering. So recall that we were talking about a 65-year-old male marathon runner. He was experiencing mild dyspnea, reduced exercise capacity, and really noticeable to him as a runner, he was experiencing slower race times. He has hyperlipidemia. He had a left circumflex coronary artery stent for angina 10 years ago, and he's on atorvastatin and aspirin. His baseline heart rate was 50 beats per minute and blood pressure 110/66. The baseline electrocardiogram showed sinus rhythm, nonspecific STT wave abnormalities. And by stage 4 of a Bruce protocol, and I'll tell you that that's 12 minutes or or about 13 METs. That's a pretty high functional capacity. He had no symptoms, and he had hit 85% of his predicted maximal heart rate, and his blood pressure was 201/80. His electrocardiogram showed no significant ST segment changes. So if we think about him being, 13 METs, 7 millimeters of mercury for every MET achieved, that's 91 plus 110, so he'd be over 2. He's right on target for what his blood pressure would be expected to be after that amount of exercise. So what's the next and most appropriate step in this case? Inject radionuclide. The patient, after all, has hit 85% of his predicted maximum heart rate and has a high blood pressure. Well, actually, it's not high. As we said, that's kind of as expected. Should we administer a nitrate to lower his blood pressure? Should we continue exercise, or all of the above? Well, let's get a little bit more information. So had we not stopped the exercise there, the patient entered stage 5 of a Bruce protocol, and at stage 5, he starts to develop dyspnea similar to when he trains. His heart rate is now 97% predicted maximum heart rate, his blood pressure 215/90, and now he has 1.5 millimeters of downssloping ST depression in leads 2, 3, AVF, and V3 through V4. Now, what I didn't tell you before is that ST segment changes just confined to 2, 3, AVF, and maybe just V6. Those are only 20%. That has only a 20% positive predictive value. But when you start involving ST depression in leads V3 and V4 or 4 through 6, that starts to have higher positive predictive value. So that's a positive response. And if we look at the nuclear imaging, there was a large, moderate severity reversible defect in the anterior wall. So looking back at this case, if we ask ourselves what the most appropriate step was when I asked the question, it was to continue exercise, because that's what answered the question. Had we injected prematurely in stage 4, we may not have seen any ischemia and may not have answered the reason for the patient why he was having dyspnea and slower exercise times. So in summary, symptom-limited exercise stress testing should be employed. And injection of radionuclide simply for attainment of 85% predicted maximum heart rate is not the best practice. 85% predicted maximum heart rate may be maximum for some patients. It may not be for others. Some patients may need a higher heart rate in order to induce their symptoms or to allow us to find ischemia. So having heard this presentation, you should be able now to explain why symptom-limited exercise stress testing is performed, explain what symptom-limited exercise means, explain how to perform symptom-limited exercise testing, know when to switch from exercise to pharmacologic stress testing, and when to abandon testing altogether. So you're allowed to make that switch if you don't feel that you've answered the question with exercise. And then we talked about when to stop stress testing altogether. You should be able to explain the content of a typical stress test report, and you now know which ECGs the IAC requires to be recorded, submitted, and why. So why did the bishop have a stress test? He had, of course, chest pain. So at this point, I'm going to stop, and we'll entertain questions. And I think either Kelly or Maria are going to host those questions. Let me know what they are, and I'll try my best to give you good answers for those.
Thank you, Dr. Cohen. At this time, we'll begin the Q&A session. And from IAC Nuclear PET, I'd like to introduce Maria Costello, Director of Accreditation. She will assist Dr. Cohen's questions today. Maria, would you like to start us off?
Sure, Kelly. So, Dr. Cohen, the first question is, if the patient is injected at symptom-limited stress, and then the treadmill is slowed down to let them walk the extra minute to circulate, is that okay?
That's a great question. I think as long as the patient's heart rate doesn't precipitously drop, then you're okay. sometimes when patients just start to poop out at that point, and so in order to conduct the test safely, you do have to kind of slow down the treadmill somewhat. I would encourage you not to just slow it down all the way to a super slow walk. I think you do have to maintain the heart rate as close to that maximal heart rate as possible in order to have adequate extraction of the radionuclide.
And the next question is from James. Is there a hazard with symptom-limited protocol of not achieving 1 minute of exercise after injection of the radionuclide? What are some ways to mitigate this risk?
That's also a great question. I find that you're always talking to the patient and you explain to them at the very beginning and throughout the test that we really need to hear from them how they're doing, what they're feeling. Let them know that when they feel like they've hit their maximum, they can't just leap off the treadmill. I tell people that's what gives me chest pain. But if you just explain that we really do need them to exercise for a full minute after they're injected, most patients will let you know, ooh, I'm starting to poop out a little bit, and most people are able to do that extra 1 minute. Here's a little clinical pearl. If you're involved with exercise testing, you can tell when a patient is kind of getting to their anaerobic threshold. That is the threshold where they're going to say, I'm done. They'll be talking with you, they'll be smiling, they'll be joking along, and then just as they're starting to get close to their maximum exercise capacity, suddenly you're going to notice that they get really serious, and the smile is no longer there. And then you might notice just a little bit of sweat on their upper lip. When you start noticing those cues, you know that you're getting pretty close. And so that can help guide you when to inject.
Okay, the next one is kind of a scenario with a question. I had a patient who was on Sotalol for years. He exercised for 10 minutes, achieved 75% of the maximum predicted heart rate. The patient was fatigued, but said he could go on for 1 minute. I had the tech inject the isotope. He could only walk 10 seconds at stage 4 after the injection. He continued to walk 50 more seconds on low recovery level. Is that a good test, or should I do a pharmacological stress test on a different day?
Yeah, that's a really good question. That's kind of a judgment question when you're right there. I guess what I would ask is, what did his heart rate do when you slowed it down that much? I mean, if his heart rate in general is pretty close to what it was when it was at peak exercise, you can probably just accept it. If it just, some people can get vagal when they stop exercise abruptly and can have the heart rate really precipitously drop. And if that happens, if suddenly goes from, I'm just making this up, 160 to 50 and feel lightheaded and you're about to pass out, then you probably do need to change over to pharm stress. And it doesn't necessarily need to be another day. There's plenty of data about injecting vasodilator stress in patients who, for example, don't achieve their 85% predicted maximum heart rate. And that's actually, if we're stressing patients to establish a new diagnosis of coronary artery disease, that's what we currently do in our lab. We will stop the exercise, recover them, and then we'll convert them over.
Next question. Is the objective to induce symptoms?
Well, if you have a patient who has presented because of symptoms, and if they say they get chest discomfort while they're running, or they're being tested because of profound dyspnea, it would be very nice to duplicate those symptoms on the treadmill. And it can often be very enlightening if you get a person who exercises a good long ways and they don't have duplication of their symptoms. That sometimes can be very revealing as well. So if you get duplication of symptoms and you inject a radionuclide and you see ischemia on the SPECT, you've really kind of wrapped everything up with a nice, neat bow, and you've answered the question as to whether they have coronary disease or not.
If a patient had coffee less than 12 hours prior to exercise, should they be rescheduled?
Yeah, we generally do, because if we do have to convert them, you do have that caffeine on board, and if you were to give them vasodilator stress and you had a normal, you'd really not know 100% for sure whether it's normal or whether that's a caffeine effect antagonizing the effect of your vasodilator stress. Now, with that said, there is some data that supposedly regadenoson as opposed to adenosine may be less affected by caffeine, but clinically, I would not hang someone's life on it.
And the next question: if a patient is beyond 85% but doesn't have any reproducible symptoms, do we stop the test and go to pharmacologic testing?
So if I understand this correctly, the question is, patient's doing fine on the treadmill, they maybe have hit 90% predicted maximum heart rate, and they feel fine, they can keep going, but someone wants to stop the test and convert it over to pharmacologic stress. I would say no, I would not do that. I would let them go till they're done, and with a minute's notice, you inject, exercise them for that additional minute, and when they eventually call uncle, you lie them down and eventually image them. In this game of man versus machine, the machine always wins. It is a very, very rare patient who can max out a protocol. I've seen it only a couple of times in really elite athletes. I had one person who went, if I recall correctly, it was like 21 or 24 minutes. I think it was like 24 minutes on a Bruce protocol. And it was actually the staff and I who actually called uncle, not the guy who was being tested.
Okay, so the next question, what if the patient was injected at 85% but continues to exercise? So I am thinking that this question means that they hit the 85% and then they injected them, but they weren't necessarily out of breath or anything like that with no symptoms. Is that still considered a good stress test?
So, yeah, every once in a while someone will go, I think I need to quit. And you go, ooh, okay, and then so you inject them, and they go, well, actually, I'm feeling pretty good. And then they keep going. So they kind of sandbag you. It does happen. Look, what I would do is I would just continue to exercise them, because you get a lot of clinical information from the treadmill portion of an exercise test. The longer a person can go on the treadmill, the more METs that they can achieve, the better their prognosis. And so it's not like you're going to spoil the nuclear part of the stress test. You might get additional clinical information by having them keep going. So, if in that scenario, I probably would just allow them to keep going.
Okay, so then even if they were injected at 85%, it won't change the outcome because they went further?
No.
Okay.
No. When you inject the radionuclide at 85%, you'll be a snapshot of what the myocardial perfusion is at that moment. Now, let's go back to what we said during the talk. If you did inject prematurely, like take that marathoner that I showed you. If someone had injected 85%, he goes another stage. That's when he developed the symptoms and his ST segment depression. So in that particular case, you missed the diagnosis. So if that were to happen to you, then you'd have to make a decision as to whether the test needs to be repeated or whether some other type of testing needs to be done.
So which are the best leads to monitor the exercise test?
So the standard leads, you actually you hook them up with what's called exercise leads. They're usually limb leads that are placed proximally, and then the standard V1 through V6. We monitor, I think it's 2F and one of the V leads. I think it's V6, if I'm not mistaken.
Okay.
But you can actually change those. I mean, for example, if you have a better quality lead, if you have Artifact, for example, one of those leads I just rattled off, if you find that you have a better quality lead, you can look at those. I mean, you're going to be monitoring. Perhaps those 3 leads, but then you do get a 12-lead ECG at every stage. So you're going to be on one level. You're going to be monitoring all leads at some point during the test.
Okay. A patient with an AICD, you mentioned injecting before you reach the AICD setting. Is that as long as that they are not being paced?
Yeah, because an ICD has both pacing functionality and defibrillating functionality, and you need to know at what heart rate you're going to get a shock delivered or rapid anti-tachycardia pacing. So it's that threshold of the rapid pacing or the defibrillation threshold for when a shock is going to be delivered. You need to know that and stop before you get to that.
Okay. Are we suggesting to continue exercise beyond 100% if there are no other contraindications for continuing?
Yeah, you can do that. And we do have some patients that do that. I mean, you just have to monitor the patient, make sure that they're clinically doing fine, make sure that they're not having chest discomfort or other symptoms that might be indicative of ischemia, make sure the EKG looks okay, make sure that their blood pressure is still on the rise, that it's not falling.
I was taught in the past with using Symptom-Limited, it is ideal to have the patient walk at least 2 minutes before going into recovery. Is that correct?
Well, I mean, it's not incorrect. There's no harm in having them exercise a little bit longer. The more circulation time, you are going to get a little bit more extraction, but I guess what I'm trying to say is you have to have them go at least 1 minute.
For a combination of exercise and Lexiscan, what protocol should be used for the treadmill? Is there
so it's not really the regadenoson that's going to determine whether you choose a protocol or not. It's the patient. You need to choose a protocol that the patient can actually do for at least 4 to 6 minutes if you can. So if a person is a pretty slow walker or, kind of shuffles along. Look, if a person walks into your lab, then they ought to be able to do a Naughton protocol. That's a really, really low-level stress. That stress test starts at 1 mile per hour, never gets faster than 2 miles per hour, and every 3 minutes just gets a little bit steeper. So if a person walks into your exercise lab, they can probably do a Naughton protocol.
What about a patient with a heart rate less than 85%? What criteria do you use if the heart rate is still quite low but feeling fatigued? I think that probably means, do you switch them to a pharmacologic or do you inject?
Yeah, I think you have to use a little judgment there. If you have duplication of their symptoms, if they're not at 85%, and that's exactly the reason why they're having the test, then you want to inject them because you might be able to answer the question, well, here's their symptoms. Do they have ischemia at their maximum tolerated exercise and these symptoms, even though they haven't hit 85% of their predicted maximum heart rate? Now, say it's profound fatigue and a little shortness of breath, and they're only able to get to 70% of their predicted maximum heart rate. They may have what we call chronotropic incompetence, meaning that they're not able to mount an adequate heart rate response, and that might be the answer for their symptoms. It might mean that they need a pacemaker.
What is your opinion on stressing patients on beta blockers?
Great question. Comes up every single day. So you have to ask yourself, what's the purpose of the test? If the reason for the test is to establish a new diagnosis of coronary artery disease, in other words, there's a patient with no previously known coronary disease and they're having some symptoms, and you want to know, yes or no, do they have coronary disease, then you do want to hold medications that are anti-ischemic. So you want to hold the beta blockers, you want to hold the nitrates, you want to hold the calcium channel blockers. On the other hand, if you have a patient with known coronary disease who's on medical therapy, the question shifts a little bit. It's not whether or not they have coronary disease. The question is whether they have ischemia on their best medical regimen, or at least the medical regimen that they're on. And so in that case, we will stress the patient on their medical regimen, including beta blockers.
Is there a minimum workload in METs that is considered acceptable? Some of the docs that I have worked with use 6 METs as a minimum acceptable workload.
It's an interesting question. I've never really thought of it that way. All of the guidelines really are looking at heart rate achieved as far as whether a test is diagnostic or not. It really doesn't look at METs achieved. I guess another way to look at it is post-MI, a reason for termination of the test if you're doing early stress testing, like 48 or 72 hours after an MI, you're supposed to terminate the stress test at 70% predicted maximum heart rate or 7 METs. So I guess what I would say is that you probably want to, extrapolating from that, I guess you might want to achieve at least 6 or 7 METs. But it's generally you're talking about heart rate that you want to achieve, not the METs.
I think we have time for a couple more questions. If a patient undergoes a Bruce stress test and they exercise for about 5 to 6 minutes with a heart rate of approximately 70 to 75% of their maximum predicted heart rate before fatigue causes termination, if you inject the tracer at this point, is it a good diagnostic test?
Yeah, so if it's just fatigue and they're pooping out and they haven't hit 85% of their predicted maximum heart rate, the answer would be no. You may not answer the question as to whether they have coronary disease or ischemia. And so that might be a patient that you might want to convert to pharmacologic stress.
Another scenario, I have patients that refuse to have a pharmacological stress test. And so in walking these patients, their heart rate will reach 90 to 100% within 3 minutes. Would you recommend that we still inject even though it's only been 3 minutes?
Yeah, in that case, unfortunately, you selected the wrong protocol. And that gets tricky. I do see that oftentimes that people will inject, but as I said, you really, to get a higher quality test, increase your sensitivity, you really want them to go probably a minute beyond that, like 4 minutes. So you're going to have to make the call as to whether you just stop the exercise, if you can rest them and maybe resume exercise later at a lower level protocol, or whether you have to bring them back another day. But, what you're suggesting is, the person's heart rate zoomed up and you injected probably at 2 minutes because they're quitting at 3 minutes. In my mind, that's an inadequate test. If it's totally normal, you really don't know whether it's truly a normal test.
Okay, I think that's all the time we have for the questions. We seem to be out of time.
Great. Well, thank you very much. I hope that people gained a lot from this presentation, and wish you all a great day.
Okay, great. Thank you very much, Dr. Cohen. Thanks again, everyone. Please feel free to contact IAC with any questions that were not answered during the Q&A session. To receive continuing education credit for attending this webinar, please complete the survey. The survey will appear on your screen automatically at the conclusion of this live session and also be available from the IAC Pro Libraries website for 3 business days. In the upper left, you'll click on My Webinars. Look for the title of this session, Symptom-Limited Exercise Stress Testing, Why and How. Beneath this title, you will see the link Take Evaluation. Click this link to complete the survey. Your certificate can then be accessed and printed from the very next screen and any time thereafter through a new link on the My Webinars page called View Certificate. If you have any questions about the survey, please contact us at webinars@intersocietal.org. Once again, we thank you for joining us today and appreciate your participation.